So welcome to our first ever, and now that you can hear me, high-risk case conference. So a lot of interest in this specialty, so we thought we'd start with this and sharing best practices and such. We plan to offer it quarterly, and it's based on your feedback. If you really love it, we can do it more often. So I'll just wait to hear what y'all think after this. As far as housekeeping, you're placed on mute when you enter the WebEx. So *6 to unmute, and we'll just keep this very informal, questions and comments, whenever. Also, do not put your phone on hold. We'll hear your hold music if you do, and we're also recording this WebEx. We're going to offer these special topics as we have today. I don't have this grid filled in because this is our first, and we'll wait to hear from you all as far as what you want to hear about for subsequent case conferences for our high risk. And our first one is the special topic for this quarter is high risk assessment and chemo prevention by Dr. Tynan at Rocky Mountain Breast Specialist there in Colorado. And just a little bit about Dr. Tynan, thought I'd go through a short bio. She's a board-certified general surgeon specializing in surgical disease of the breast, mainly breast cancer. She completed her general surgery residency at the University of Arizona in Tucson, and she's been specializing in breast surgery since 2009 and has built several comprehensive breast programs that achieved NAPBC accreditation under her leadership. She's an active member of the American Society of Breast Surgeons and a fellow in the American College of Surgeons. And in her practice, she offers a full spectrum of breast cancer care, ranging from supervising the breast high-risk clinic and the lymphedema prevention program. And they also there offer multidisciplinary patient consultations with med-onc, rad-onc, and with their nurse navigator. So without further ado, and a little hiccup in the beginning, take it away, Dr. Tynan.
All right, great. Thanks for the introduction. Can everyone hear me? Okay, let's go. Let's go to the first slide, please. Lori, are you gonna, there we go, thanks. So I know that all of you guys do this, but I always like to start a topic with just like a quick overview of what it is to be a high-risk cancer, patient at high risk for breast cancer. So just a reminder, so elements that increase risk, I kind of like to group them into the two, actually a couple categories. So first of all, we have family history, and then we have what I call personal risk factors. And some of those risk factors are modifiable risk factors, and some of those, of course, are not. And so we're not going to spend a whole time on family history because I don't want to, we're not talking about patients with a genetic mutation. We're just talking about patients with a family history, a couple, family members here and there. But then our personal risk factors include increasing age, race or ethnicity, obesity, alcohol consumption greater than 1 a day, which patients are often surprised to hear that. Combination hormone replacement therapy used for greater than about 3 to 5 years. Early menses, nulliparity, I don't want to say advanced maternal age because we're getting older and older having our babies, but older age at first live birth, greater than 30. Late menopause, so after age 55. And then abnormal pathologies, LCIS, ALH, ADH, and then FEA. I just want to comment on that one a little bit. NCCN has flat epithelial atypia as part of their high-risk pathology. That's pretty controversial. And actually, if you kind of look at the more recent data, most people are not considering that to be a very high-risk lesion. And in fact, we do not include it in the, when we're doing our risk calculations with the models, we do not include it as atypia. All right. So the pathologist seems to be using that less and less to decrease confusion, but just be aware if you see that on a path report, do not include that in your risk models. And then history of multiple breast biopsies, of course, heterogeneously or extremely dense breasts, and then thoracic radiation therapy before age 30. Next slide, please. So risk assessment tools. There are lots and lots of risk assessment tools out there. The Gale model is kind of I think the first one that really was used. I personally think it's pretty limited. We'll talk about these different models. The IBIS or Tyrer-Cuzick, I think some would call it the most robust. People use BRCA Pro, there's Bodacia, there's Hughes risk apps. Klaus model is based on family history. I tend to use the IBIS Tyrocusic, and NCCN also uses that for purposes of MRI, and more recently also for purposes of prescribing endocrine therapy, which we'll talk about. So the real main ones I'm going to talk about are Gale and Tyrocusic. Next slide, please. So high risk, what does that mean? So we can look at it in two ways, a couple ways. We can look at it as lifetime risk, we can look at 5-year risk, and we can also look at 10-year risk. And these different risk timeframes kind of look at things in a different way and are applied differently depending on what treatment we want to do. So women with a 20% or higher lifetime risk of developing breast cancer are considered high risk. And these are based on models largely dependent on family history. So basically everything other than Gale, okay? The average risk for a 40-year-old woman with no significant risk factors other than being female and 40 is about 12%. Intermediate risk would be considered 13 to 19%, and of course 20 and above is high risk. Now, as we talk more about cases, obviously there's 21% versus 50%. So that high risk, I find, it tends to be somewhat nebulous. And of course, patients always, everybody, I think, internalizes their risk in a different way. What's high risk for one is not necessarily high risk for another patient, even though they're technically in the high risk category. But if you want to be, specific, and as regards insurance purposes, 20% or greater is considered high risk. Per the Gale model, women with a 5-year breast cancer risk of greater than or equal to 1.7% is high risk. Now, those of you that have been doing this for a while understand that once we start getting to a certain point in life, almost everybody is high risk according to Gale, right? So again, not a big fan of the Gale model, but for a while it's kind of really all we had as far as basing our recommendations for endocrine therapy. So this last point here I think is important. So the newest version of NCCN, the 2021 updates, actually included Tyrocusic into the endocrine therapy part of things. So as this says here, per NCCN guidelines, while chemo prevention can be considered when the 5-year risk by Gale is greater than or equal to 1.7, it should be recommended when the 5-year Gale risk is at least 3%, or the 10-year risk by IBIS is at least 5%. So I think that helps us when we're seeing patients, especially older patients whose Gale model are going to be greater than 1.7%, kind of just because they're older. Then we can say, well, let's look at what your Tyrocusic risk is, kind of look at the two together. And then honestly, NCCN is kind of being a little more generous here by noting that not everybody at 1.8% really probably should be on endocrine therapy. But definitely, I like the fact that they're giving us a 3% with Gale or a 5% with Tyrocusic. So I think that helps us as we have these discussions with patients. Next slide. So the Gale model estimates a woman's risk of developing invasive breast cancer over the next 5 years and then up to age 90. So keep in mind, this is for invasive cancer. Some of the other models, including Tyrocusic, actually look at invasive and non-invasive, which helps explain why sometimes our risk is going to be higher on a Tyrocusic than, say, on a Gale, because they're including non-invasive. Traditionally, Gale was used to gauge the appropriateness of chemo prevention, designed by scientists at the NCI and NSABP. And the Gale model is not approved, and by approved I mean approved by insurance, to gauge appropriateness for screening MRI, nor does it go into the guidelines from the American College of Radiology. Next slide, thank you. Okay, this is direct from NCCN. So the Gale model, individualized breast cancer risk assessment based on SEER-specific data, 5-year and a lifetime risk. 5-year risk assessment greater than 1.67 or 1.7 and above, used to assess eligibility for chemo prevention. Now look at the column on the, well, first of all, the factors included age, first period, live birth, and family history is limited to only first-degree female relatives with breast cancer. So as we know, that does not include a whole lot of family members who may have very important information that will add to our patients' risks. Number of previous breast biopsies, and of course atypia. The benefits, I mean, it's been studied for a long time, highly validated, but the limitations are pretty big. Cannot be used for women less than 35, whereas the other models can. It's limited use in women of non-European ethnicity. Now, the modified Gale actually does take into account patients of African American, Latino descent. So the modified Gale is a little more accurate as far as non-white women, but that is one of the limitations of traditional Gale. I think the biggest underestimation is the family history, and then it tends to underestimate risk of women with atypia. Next. IBIS or Tyrer-Cuzick. Same thing, just IBIS is the one who puts it out. So again, Tyrer-Cuzick calculates the risk of developing invasive and non-invasive breast cancer. So that's an important distinction, and why, again, oftentimes Tyrer-Cuzick will come up higher than, say, a Gale. Also because of family history, but in patients, say, who do not have a big difference in family history. And this is the only model to account for both personal and more extensive family history risk factors. This comes out of University of London. Calculates the likelihood of developing breast cancer in 10 years and over a lifetime up until age 85. So similar to Gale. Gale's 5 years and 90, whereas this is 10 years and 85. And importantly, this can be used to gauge the appropriateness of adding screening MRI and of chemo prevention, and that is new this year, so pretty exciting. Okay, next slide. And this breaks down the IBIS a bit more, again, based on data from United Kingdom, a cancer registry from 2005 to 2009. There are different versions of this, be careful. So a lot of the imaging centers are using version 6 or 7, okay? Our genetic counselors, I'm sure, will tell you that they feel that version 7 overestimates a little bit based on family history as compared to 6. However, 6 does not have any breast density ability to input that information, which, as we know, is important in risk. So version 8, which is the most updated version of Tyrer-Cuzick, and the one I'd recommend that you use, does include breast density. And if you play around with it a little bit, which I'm sure we have, sometimes we're like, well, what if I change this? How does that change my overall risk? Especially those extremely dense breasts is important information. And so you can see the factors included: age, reproductive history, BMI, which we know is also important and is not included in Gale, hormone exposure, more extensive family history than a Gale model, atypia, LCIS, density, and then right now we still only have BRCA1 and 2 on Tyrer-Cuzick, although I'm sure that one of their updated versions that will come out will include other testing. Limitations. So does not consider risk from mantle radiation. I mean, honestly, we all know that those patients are at high risk. I don't know that we necessarily need a risk model for that. And then I would say the thing that I find with Tyrer-Cuzick is that I would agree that it overestimates risk for development of breast cancer in patients with atypia, dense breasts, and the other thing that's not on here that I find hyperplasia. I think that you can add. It has an option for adding just hyperplasia, so not atypia, but simple hyperplasia. I think it overestimates a little bit on that as well. Okay, next slide. Okay, so our risk reducing strategies. I put increased screening on here, although it really doesn't reduce your risk, right? I mean, whether you screen or not, that doesn't decrease your chance of developing breast cancer, but certainly the increased screening catches cancer earlier. So I would say that it is risk reducing in that it reduces the morbidity of breast cancer. So again, yearly mammogram and MRI staggered by 6 months, and then Q6 to 12-month clinical breast exams. I have conversations with my patients. If they're seeing their gynecologist every spring, I'll see them every fall. We kind of can split up those breast exams, especially as your providers and who's doing breast exams and not. My very high risk, I'll see them every 6 months, or our clinic will. And sometimes we only see them every 12, but we're definitely doing the mammogram and MRI staggered. Depending on interest, we can talk about, risk benefits of MRI, and that's a whole different topic, but per guidelines, that's what we offer. And then, of course, lifestyle modifications. So those are some of those personal risk factors that we can help patients improve We can't do anything about, age at first menses or first baby, but we can certainly help with lifestyle modification. So limiting alcohol intake, certainly less than one a day would be good, but at least no more than one a day. Daily exercise. They talk, actually one of the things that was updated in NCCN this year was they used to have their exercise kind of parameters a little bit differently. Now they say, kind of daily activity, even if it's just walking up the stairs rather than taking the elevator. But they also recommend the 150 to 300 minutes of moderate intensity of physical activity per week. It used to say, I think, like aerobic activity. They just want people to do something, right? Weight control, BMI of 20 to 25. That's pretty tight, pretty thin. And then limiting HRT use, so 3 to 5 years. We always say, the lowest dose for the lowest time possible. But again, these are conversations with your patients. Some of them are really attached to that HRT, so those are kind of, sometimes it's a little bit of a bargaining with your patients on that one. Risk-reducing surgery. Again, per the textbook, we really do try to limit our risk-reducing surgeries to patients who have genetic mutations. In reality, there are just some patients who may not have a genetic mutation, but have a strong family history, they're at high risk, they watch their mother go through metastatic breast cancer treatment, and they want mastectomies. So I think most of your breast surgeons will say that when it gets right down to the nitty gritty, there are some patients that we do operate on that are not genetic, but are certainly appropriate for mastectomy. And then risk-reducing agents. So let's jump into that. So that's why we're here. Okay, next slide, please. Okay, so chemo prevention. So we have our two types of medications that we use. We have our selective estrogen receptor modulators and our aromatase inhibitors. And so our SERMs are synthetic non-steroidal compounds that block estrogen action by binding to the receptor. And so tamoxifen and raloxifene. And then our AIs, which suppress estrogen levels by inhibiting the creation of estrogen by inhibiting the aromatase enzyme. And so the two that are used for chemo prevention, exemestane and anastrozole. Next slide. And again, this is straight out of NCCN, if you wanted to look at this later. So tamoxifen, raloxifene, aromatase inhibitors. So, tamoxifen is the only one that is approved in premenopausal patients. The risks of tamoxifen, as I'm sure you all know, include blood clots, cataracts, uterine cancer. Raloxifene is pretty easy to take. I mean, not a lot of side effects from it. It's appropriate in our postmenopausal patients. And our aromatase inhibitors are only for use in postmenopausal patients, and of course, use is off-label. So the only two that are actually FDA approved for risk reduction are tamoxifen and raloxifene. Although, we do use those aromatase inhibitors. Now, the aromatase inhibitors, the big thing to look out for is, of course, bone loss. We can use our bisphosphonates to help decrease that, and it can be harder to tolerate, certainly, than raloxifene. And what else are they going to say on this one? Okay, next slide, please. Okay, so what are indications for prescribing chemo prevention or endocrine therapy? Chemo prevention just sounds so scary to patients, right? They hear chemo and they kind of, freeze. So I always kind of say, chemo prevention, just meaning medical management or medical prevention. So patients that are at least 35 years or older with a life expectancy of at least 10 years, kind of makes sense. And then a history of at least one of the following. So thoracic radiation administered prior to 30 years of age. So those patients who were treated as kids or young adults. History of LCIS, lobular carcinoma in situ. Depending on the data you look at, LCIS anywhere from 1% per year risk up to 20% risk at 10 years of developing breast cancer. So that's a real good conversation to have with your LCIS patients. Again, consider, those are the new NCCN guidelines, consider for those with a 1.7% or greater 5-year risk, all right? Recommend when Gale risk is at least 3%, or again, when that tyrocusic, that's a typo, I apologize. Tyrocusic risk is at least 5%. Sorry, that should be 5%, not a 10%. And then atypical hyperplasia. Tamoxifen decreases the risk of developing breast cancer in patients with atypia by 86%. That is pretty impressive. And the thing that I like about that is we'll talk a little bit about some newer dosing on tamoxifen that makes it much more easier to tolerate. So I think we can really make a big difference in patients' lives, especially those patients who have ADH or ALH. So indications for breast cancer chemo prevention. Chemo prevention is supported by guidelines, NCCN, ASCO, and USPSTF latest actually did come out with guidelines to support endocrine therapy. Again, tamoxifen and raloxifene FDA approved, AI is off-label. And use of chemo prevention in BRCA carriers or other patients with genetic mutations. You know, this kind of goes back and forth. When we look at this, there's not a whole lot of research on how well these medications work in women with an inherited mutation. That being said, there is some data to support that, especially in patients, you know, who could go on to develop ER-positive disease. Now, as we know, patients with genetic mutations have a higher risk than the general population of developing ER-negative disease. That being said, if we have patients with inherited mutations that for whatever reason do not want to undergo surgical prophylaxis or are waiting for a certain period of time, I think it would be extremely reasonable to help mitigate their risk with endocrine therapy. I mean, you certainly couldn't be faulted for that. Next slide, please. Great. All right, so what to choose? So premenopausal women, 35 years old or higher, who have completed childbearing, the standard of care is 20 milligrams a day for 5 years, okay? Again, you know, I think sometimes we forget this. Tamoxifen is a teratogen, right? So we do not want our patients getting pregnant while they're on tamoxifen. So it's important to have that discussion with them. If they are premenopausal, obviously they could still get pregnant. So make sure that they are on some sort of a birth control so they do not get pregnant on tamoxifen. Now, low-dose tamoxifen. We're calling it, my medical oncologist and I are calling it baby TAM. Maybe an alternative in women unwilling or unable to take standard dose tamoxifen. It's really pretty exciting. So it's a 5 milligram dose taken only for 3 years. I'll talk about at the end, there's a paper that just came out, I want to say it was in September, that was a randomized controlled trial comparing patients taking this baby TAM versus placebo, and they looked at their outcomes, and the ones taking baby TAM had excellent risk reduction, so less breast cancers, and they had almost no side effects, okay? So between them and the placebo group, a slight increased complaint of hot flashes. That was it. Most of them kept their menses. They didn't have the vaginal dryness, all of those things that make tamoxifen so hard for our patients to take. And the risk, the incidence of, complications such as cataracts, DVT, PEs was also comparable to placebo. So very exciting. In fact, my medical oncologist, she's using this now for our DCIS patients as their post-operative chemo risk reduction. Tamoxifen use for 5 years reduces risk of breast cancer for at least 10 to 20 years in premenopausal women, particularly those who have ER-positive invasive tumors. Again, that's extrapolating from breast cancer treatment data, but we feel that we get that risk reduction for a long time. And then again, anastrozole, exemestane, and raloxifene not appropriate for premenopausal women. Postmenopausal women, we have a lot of choices. I think most people really do try to take tamoxifen to do that if they can. Obviously, if our postmenopausal women do not have a uterus, that makes it much easier to give tamoxifen. But, depending on tolerance to anastrozole or exemestane, raloxifene would be great, but sometimes we do the postmenopausals on tamoxifen as well. Next slide. So again, deciding which ones to use. The SERMs, so tamoxifen and raloxifene, we do worry about thromboembolic events. So that would be where we may have patients on an AI, say, instead of raloxifene. So patients with a history of DVT, PE, strokes, TIAs, or prolonged immobilization, meaning therefore at risk for PEs and DVTs. Raloxifene compared to tamoxifen is associated with lower rates of this. And again, baby tamoxifen, baby tam, lower dose, 5 milligrams, 3 years instead of 5, less side effects, essentially equal efficacy. Is this the way we're going to be going in the future? We'll see. AIs, again, worry about bone mineral density reduction. So we don't want to give it to women with a history of already documented osteoporosis. But those who do have bones that are acceptable, we can help maintain that density with bisphosphonates, denosumab, or even, weight-bearing exercise. I think that's it. Is there a next slide? No. Questions?
Please unmute if you star 6 to unmute if you have questions, or you can enter them in the chat if you prefer that.
I have a question. Can you hear me?
Hey,
yes.
Lisa. Yes.
Hi, this is Michelle Dixon in Portland.
Oh, sorry, Michelle.
Hey. I'm new to the guidelines. I've just started this practice here in the last year, and I use something called the Friedman tables that I think are referred to in the guidelines to help me figure out whether a patient is a candidate for raloxifene or tamoxifen. It's based on their Gale score. It's it's based on a big trial that compared the risks and benefits based on Gale score, age, presence or absence of uterus, and race. Do you use those? I haven't heard anybody else refer to those yet.
I don't actually. I want to write it down though. I'm interested in knowing what that is. What's it called again?
So it's Friedman, Freedman. It's referred to in a footnote in the guidelines, and there are tables, and I can actually get Lori to send you a copy of those and the study.
Sure. Yeah, that's interesting. I haven't. I mean, it may well be a good one to use. I think that really, I think that all of these different risk models and the guidelines are guidelines, right? And these are all discussions that we have with patients. I think that if you have data you can show patients and talk about, why I think that you would benefit from risk reduction measures, be it just lifestyle changes, be it additional screening or endocrine therapy, that you're on the right track.
Okay, thank you.
Sure.
And in our chat, Gail asked, can we share them with everyone? Absolutely. So, Michelle, if you can get those to me, that'd be great. Thank you. Any other questions? We did have 2 questions submitted, actually, while we had have our expert. She wasn't able to attend, or maybe she's just listening in, but Dr. Tynan, if you would address these, that'd be great.
Sure. So actually, we kind of talked about this first one. So if a patient has a high 5-year Gale score, but a normal to moderate lifetime risk using TCV, sorry, that's what we call it, Tyrer-Cuzick version 8, would you still give tamoxifen if the lifetime risk of breast cancer is not high? So, again, I think that Gale, depends. Is this an older patient, right? Because our 65, 70-year-olds, they're going to have a high Gale score. I would look at the 10-year risk of Tyrer-Cuzick, and if it's greater than 5% plus a high Gale score, I think that's pretty good evidence that you could offer. The new guideline allowing us to use Tyrer-Cuzick, I think, is really, really going to be helpful for everyone. And then pertaining to age, well, there you go. Anyone age 60 plus has a Gale score that is 2-ish. And again, I would incorporate another risk model using family history. So Tyrer-Cuzick would be helpful for that.
Thank you. And I see a question in our chat about when to reassess. When do you graduate from high risk, or if you graduate from high risk?
Yeah, that's a great question. I don't know that anyone really knows the answer to that. Especially if they're not doing chemo prevention, what you can do is, so if we're not doing chemo prevention, some people do graduate out of high risk once they reach a certain age, and then, they're no longer in that high risk category because they've kind of beat the odds, if you will. I will periodically rerun the tables to see where we are. As far as our, endocrine therapy, so they've, finished their endocrine therapy. Are they high risk? I guess it depends where their risk was when they started, right? So if we, generally say that tamoxifen decreases risk by about half, okay, for a standard, let's say not an atypia patient, because we know it's more effective for them. Once they've reached that 10-year, that 20-year threshold, are they, oh, sorry, I was distracted by the chat. Are they back to being high risk, or are they in a whole new, do we recalculate their risk? And as far as after completing their endocrine therapy for that 5 years, their risk is decreased by half. So was their risk 50% to start with? So another 25%, they're still high risk, right? And so I would still continue the screenings. If that risk was, 30%, and now they're in that intermediate 15% area, we would definitely recommend the yearly mammogram, certainly not the every 2-year mammogram. So it kind of depends where you start as to when they're no longer high risk and how old they are, I would say.
Thank you. And Michelle, was that the guidelines you spoke about that you just published the URL in the chat?
Yes, I'm terrible at this technology stuff, so I'm sorry about that. I just found the link and I put it in, so it was there, and I didn't have my mute. I don't want to unmute and do anything else. Sorry about that.
Okay, no problem. This is informal. This is great sharing of knowledge. Okay, any more questions in chat? Or otherwise, we'll go to our only case. Sherry at RMCC has a case, if you want to unmute and present.
Very good, thank you. So SL is a 50-year-old female patient who was found to have DCIS in late 2013. She first underwent lumpectomy, and then in March of the following year, she underwent right mastectomy, and again confirming DCIS. She started on tamoxifen, and she completed 5 years of tamoxifen. In April of this year, she underwent biopsy of the left breast, which shows hyperplasia. She does have quite the family history, a paternal aunt and 2 paternal cousins, all with breast cancer diagnoses prior to age 50. One of those cousins passing away with metastatic breast cancer. Genetic testing was performed in 2014, negative for the BRCA mutation. Repeat genetic testing earlier this month was negative for any variants. So she's got quite the history here, family history, personal history, both breasts. And so I guess my question at this point is would it be prudent to revisit tamoxifen?
What was her hyperplasia? Was it usual hyperplasia, or was it atypical hyperplasia?
Atypical.
Atypical. What, ductal or a lobular?
Ductal.
Has she had that excised?
She did.
And so final path was just ADH.
Yep, that is correct.
Okay. Yeah, I think with that diagnosis of atypia, and her family history, I think it would be pretty hard not to offer again. Is she still premenopausal?
She is premenopausal.
Premenopausal. Mm-hmm. I think it's a good discussion to have with her. I mean, kind of one way that I personally would frame the discussion is to say, because sometimes patients, and I don't know how this patient has reacted to this, but they're like, look, I had my breast cancer, okay? I took my tamoxifen. Why am I getting this again? And, perhaps being on that tamoxifen for 5 years, this biopsy was just atypia and it wasn't cancer, right? So did that help her down, did it help keep that from going? We know that tamoxifen is very effective at preventing atypia from progressing to cancer. So I don't think it would be unreasonable. You might want to talk with her about the lower dose tamoxifen, right? Because that would be a lot easier for her to tolerate. And if she decides not to, then certainly I would definitely put her back on high risk screening.
Okay. That answers the question.
Great.
Great, Sherry. Thank you for the first case and only case. We really appreciate that. Any other questions? Chat or *6 to unmute. We'll have a short one this month or this quarter. Really appreciate you, Dr. Tynan, taking this on and presenting today. We do have those 2 slides, the baby TAM clinical trial information. Do you want to share those?
Yeah, would you guys like to see those?
Sure.
Yes, yes.
Okay, great. Yeah, so this is, it came out in, I saw it was September, but anyway, 2019. Okay, so last year. So this is a randomized controlled trial of low-dose tamoxifen, and this was done in patients with both atypia and with DCIS, okay? And this is kind of the, wrote out the abstract here. You can read this. So 500 women, 75 years of age or younger included, multi-center randomized trial, 5 milligrams a day versus placebo. So the first 3 years after surgery in women with hormone-sensitive or unknown intraepithelial neoplasia, so atypical ductal hyperplasia, lobular hyperplasia, and DCIS, and lobular IC, or LCIS as well. So really those intraepithelial lesions. And 14 cancers in tamoxifen and 28 in the placebo, so half, okay? And then the patient-reported outcomes were not different between arms, except for a slight increase in daily hot flashes with tamoxifen. And there were 12 serious adverse events with tamoxifen and actually 16 with placebo. So, actually the placebo patients in a way did worse than the tamoxifen patients. And we had 1 DVT and 1 stage 1 endometrial cancer with tamoxifen. And there's 1 pulmonary embolism with placebo. So I would argue that that our patients could benefit from a lesser dose of tamoxifen and still reap the benefits of it. I think there's a chat question. Let me see.
There's actually several. Yeah.
Oh, go ahead. You want to read those?
I will. If a woman has risk over 20% and they have never had an MRI or mammogram, how do you decide which imaging technique to start with?
Yeah, that's a great question. So anyone over age 35, actually anyone probably over age, 30 to 35 is a little tricky as to regards mammograms. You might talk with your breast imagers, but definitely over age 35, I would start with mammogram, okay? MRI is a great tool, but like I tell patients, MRI is kind of like, taking pond water and looking at it with a magnifying glass. You're going to see a lot of stuff and not necessarily know if that's benign breast tissue, if it's, atypia. So baseline mammogram is great. You're not going to see calcifications, right, on an MRI, which you will see on mammogram. And so if a patient has DCIS with calcs, you won't see it on on MRI. So now younger patients. So my young patients, my 30-year-olds, I don't typically do mammogram on them. Because oftentimes those mammograms are so dense that you're not getting a lot of information. So sometimes on the really young ones, I'll do a yearly MRI, and then I may do whole breast ultrasound. So if you have that in your community, that's a good option for the younger patients. But between 30 35, it depends a little bit. If they're not super dense, they could benefit from mammogram. But in your standard older patient, definitely mammogram first.
Excellent. Another question. Does high-risk screening need to be done every 6 months, or can mammogram/MRI be performed at same time each year? And this person said, I thought I heard somewhere that outcomes were the same in both scenarios.
Certainly it depends. So outcomes are an interesting thing, right? And so when we talk about, early detection of breast cancer, or, I'm trying to think of the exact example I want, but, we talk about outcomes of, so risk-reducing mastectomies, for instance. I have this conversation with my patients all the time. And especially those patients who do not have a genetic mutation, yet we're still going to do risk-reducing mastectomy for. So like an LCIS patient who's had multiple biopsies and is like, look, I'm just done with this. Can we do mastectomy? So I'll say, okay. We know that the outcome, okay, so there's 2 outcomes, right? There's morbidity and there's mortality. So the risk of dying from breast cancer is one thing. The risk of getting breast cancer and having to have all the treatments is another. And so when I think of outcomes, I think of it in that way. So I might not decrease your risk of dying from breast cancer by doing a certain thing, but if I can certainly prevent you from getting breast cancer or find it sooner, that's a great outcome, right? And so the reason for doing the staggering is every 6 months, we're getting a look at that breast tissue. That way, if something develops, and oftentimes patients who are at high risk of breast cancer are going to get more aggressive breast cancers. So wouldn't you rather find triple negative breast cancer within a 6-month interval rather than a 12-month interval? So that's the purpose of the staggered, so that every 6 months we're looking at that breast tissue rather than doing it all at once and then going a whole 12 months before doing it again.
Excellent. Thank you. I don't have any other questions in the chat box. So give it a second.
If folks think of something afterwards, just send me an email.
Great.
I'm happy to answer questions or get more information. I'm always open to new things like this Friedman thing. I'm going to look that up as soon as we're done here. See what that is.
Thank you. Love that.
Okay, I'm just going to briefly, I'm just going to briefly give, I'm trying to do a screenshot, but I couldn't do it. But it is in the NCCN guidelines in the version 1, 2021, and it's the page that follows the tamoxifen, raloxifene, and aromatase inhibitors agents.
One of the footnotes.
It's a footnote, yep.
Yeah. Okay, great. I will look at that.
Thanks, Michelle. So I have it scheduled for September 24th, same time, 4 to 5 Central. What I'll plan to do is send out a survey to all that attended and maybe get your feedback on what we can do. Should we do more often? What topics do you want to hear about? That kind of thing. So get your feedback. And now I see another chat. So juices are flowing. Dr. Tynan, we have, so are you discussing the baby TAM in all of your patients with no cancer history and meet 1.7% requirement? What is your target patient for that option?
Yeah, great. So yes, I'm discussing baby TAM, especially with my patients with atypia, okay, because we know that the data shows that tamoxifen is so effective in those patients, 68% reduction. The 1.7%, again, I'm not a big fan of Gale. I use Tyrer-Cuzick, and so I look at that 10-year risk. And if it's above 5%, we do have a serious conversation about using it. I just think the baby TAM is so much easier to take. It is in NCCN guidelines as a kind of a, if patients won't take or don't tolerate. So I think that sorry, I'm distracted by the chat about baby TAM. So yeah, I think it's totally appropriate. And yes, the new publication, so someone's asking, the original observational study included patients with DCIS, and this does include DCIS as well. LCIS, DCIS, and atypia.
Thank you.
Hey, Lori, I can send you, I have that as a PDF. Do you want me to send that to you if you want to send it out to folks interested?
I'll send out your slides, the recording, and yes, Dr. Langer says please send. Thank you, Dr. Langer. And we'll get all this wrapped up for everyone and Michelle's information also. Thank you so much. I think this is going to be something special, and we're going to get better. I'll get better and better at it each time. So thanks again, and I guess we'll wrap up if that's. I don't see anything else coming in the chat, and your feedback's welcome. So let me know what you think.
Great,
thanks for attending.
Thank you, everyone.
Thank you.